to another educational webcast from FEC. We've created it for your information and professional competence purposes. Hopefully, after watching this webcast, you should feel more confident when confronted with a similar clinical situation. This information should increase your understanding of CPGs and help you to become a better practitioner. You should understand that webcasts are not intended to replace a full training course, but watching this webcast should definitely help inform your practice, improve your clinical effectiveness. Practitioners must only act in accordance with CPGs and their current scope of practice and status on the register.
Treating pain is one of the most important roles we have as practitioners. It's how patients view us as practitioners, and if we can help ease or relieve pain, then they perceive that their experience with us has been a beneficial or positive one. 50% of patients presenting to emergency departments do so with pain. So the number of interactions we'll have with patients who have pain is enormous. Having a structured and organised approach and having a compassionate attitude towards dealing with pain is very important. We should consider pain as a very important marker of actual or potential tissue injury within the body. And we should acknowledge this as a warning sign that we need to see what process or what event is going on to cause the patient's experience of pain. Patients often find that the fear of pain is actually more worrying than the pain itself. You'll often find that someone tolerates a musculoskeletal injury quite easily because they know that they've banged their leg, it's bruised, it's swollen, it's sore. People might react much more severely with an unexplained pain, such as an abdominal pain or a headache, because they're afraid that there is something more sinister or potentially life-threatening going on. So when we assess pain, we can use a variety of tools to do so. The most common that we use is the visual analog pain score, where we ask patients to rate the pain from 0 to 10 in a linear manner. We often give patients benchmarks of what these pain are, so that we have a reference point, bearing in mind that very young people often don't have any experience of pain at all. So what they might call 10 out of 10 the worst pain in their life reflects their lack of experience of pain compared to, we'd say, an older stoic patient who's experienced an awful lot of pain and may be more conservative in how they express that pain. So we use the visual analog score in conjunction with the patient's appearance, their physiological parameters, and other factors such as the ease of which they move or the posture they assume as markers of pain. Quantifying the extent of the patient's pain is a very useful tool for us. It guides us with the level of analgesia that we can provide, and then reassessment or reevaluation lets us know if our therapy has been effective. Let's take, for example, a patient with a mild pain. Their pain score will be less than 3. Our pain interventions in this scenario can be to explain the cause of the pain, to provide reassurance. We can consider Entonox, or if there's a physical injury such as a wrist or an ankle injury, splinting or non-pharmacological interventions can be extremely useful in this case. As patient's pain progresses and goes from mild into moderate pain, so a pain score of 3 to 4, we can consider some pharmacological interventions. Entonox, if there's no contraindication, is an excellent choice, but we've also got the choice of 2 oral medications. In adults, we would use 1 gram of paracetamol, provided they have not had it within the last 6 hours, and we can use that on its own or in conjunction with ibuprofen, which is a non-steroidal anti-inflammatory. The dose is 400 milligrams, provided they've not had it within the last 8 hours. As pain progresses and becomes more severe, we may need to use stronger pain relief. Morphine, an opiate analgesic, is an excellent form of pain relief. In adults, it can be given in 2 formats. Intravenously is the first line, or intramuscularly can be used when intravenous access is not possible. The intravenous dose is 2 milligrams, repeated every 2 minutes, up to the maximum set in the current clinical practice guidelines. The maximum dose for intramuscular morphine is 10 milligrams. The CPG states that intramuscular morphine should not be used for patients with chest pain. The rationale for this is that the intramuscular injection can damage muscle cells in the area, cause an increase in a muscle enzyme called creatinine kinase, and this may interfere with the biochemical assessment of the chest pain in hospitals because creatinine kinase is one of the markers used.